Just remember to just remember to mute your mic so that way we don't get any feedback throughout. So my name is Dylan Wood. I'm one of the fourth year medical students at University of Kentucky College of Medicine. I'm one of the co-presidents of our local interest group, along with Kate Cox, who is a third year medical student at UK. Today we have Dr. Nicholas Elwert. Dr. Elbert is fantastic, and we're glad to have him on tonight. He's the medical director of stroke rehab at the University of Kentucky. He also goes by Dr. Nick, and he'll be with us tonight. So Dr. Nick, if you want to introduce yourself and say who you are, your position at the university, and kind of what we're talking about today.
Yeah, certainly. Thanks, Dylan. So first off, thanks, guys. First off, for being cool with a little audible at the last minute. I was very sick last week, and you will hear the occasional sniffle or the occasional cough. I apologize, but you would have probably gotten a lecture with me having taken some cough syrup because I was terrible and laying in bed. So that wasn't my best, and so I want to give you guys my best. As Dylan said, my name is, I go by Dr. Nick just because it's easier to say. I am one of the faculty at University of Kentucky PM&R program, residency program. I'm our stroke director and our assistant program director for our residency. And tonight we're going to be talking about stroke rehab. Long story short, I went into residency thinking I was going to do sports and spine, and found out that as I love musculoskeletal medicine, I'm passionate about stroke rehab, and here I am. So we're going to talk probably for about 40 to 45 minutes. At the end of this lecture, I'm really hoping that as you guys, I see kind of students from not only all over, but also of all different years. My hope would be is as you go on your neurology rotations, your neurosurgery rotations, and then your PM&R rotations, that you find this lecture helpful in answering the tough questions, because that's something that is that you prepare for in residency. But until you're an attending and you're being asked, Doc, am I ever going to walk again? Those are tough questions to answer. So that's what we're going to go through tonight. Before we get started, I'm going to leave my contact information in the chat. I know some people may have to head out early, and that's totally fine. But my email and my cell phone are in there. By all means, please feel free to reach out to me, whether it's stroke rehab related or even residency related about UK's program or just residency in general. So let me go ahead and share my screen. All right, can you guys see that? Okay, perfect. So when it comes to lectures, first off, I have no disclosures. When it comes to lectures, we have to make sure that we set out with some objectives. And then I'm also very much of a component in how I learn. I'm very much an advocate for active learning. So we're going to go through some questions. And then by the end of the lecture, if I've done my job, you guys should be able to answer the questions with ease. So these are the three main things that we're going to talk about. We're going to discuss this nebulous term called neuroplasticity. You hear it on commercials, you hear it on like Chicago Med, and what does it actually mean is what we're going to go through, and how its role plays in our rehab realm. We're going to talk about the history of stroke rehab, because if we don't know where we came from, we don't know where we're going. And then we're going to talk about the role of technology. I'm going to show you what the literature shows. I very much practice evidence-based medicine and want to make sure that we're giving our patients the best. So that's what we're going to talk about. So talked about questions. So if you have a piece of paper out, or if you just want to remember, this is the first question. So peak neurologic recovery after a stroke occurs when? Within the first 8 months after the onset of symptoms. And when I mean onset of symptoms is that's when someone had slurred speech and weakness on one side of their body. Is it B, within the first 8 to 10 months after the onset of symptoms? Is it C, within the first 1 to 2 weeks? Or is it D, within the first 1 to 3 months? let you guys think about that for a couple minutes. All right, next question. What is the most important predictor for stroke recovery? Is it the patient's initial stroke severity score, called the NIHSS? Is it the age of the patient? Is it the type of stroke? Or is it none of these and I'm just trying to throw you off? And then the next question is probably the hardest. Which of the following robotic devices demonstrates the best improvement in ADLs and upper limb recovery after a stroke? Is it hand end effectors, hand exoskeletons, arm/shoulder end effectors, or arm/shoulder exoskeletons? All right, let's get first talking about the history. As I mentioned, I can't do and discuss stroke rehab justice if I don't talk about where we came from. So believe it or not, in the late 19th and early 20th century, there was very little in what would be referred to as rehabilitation for stroke survivors. It was really only the early 20th century where you started to see some very basic therapies, such as simple word repetition, just passive movement of the individual's weak limb, use of really rudimentary devices for ambulation, and some contracture prevention. But that was really it. It was very basic and just very, very, very simple. Now, this picture here is is a demonstration of one of the rudimentary devices that was used. It's a little difficult to see. I think this is probably the best picture where you guys can see my mouse. And this is essentially just a stick that this stroke survivor is using on their right side. So I would guess that based upon this patient's symptoms, they had something in the right side of their brain because their left side is affected. You know that because that left elbow is flexed and you can see that that leg is kind of swinging out as this person is walking. Plus you can tell because this cane is on their right side. But this is what they use. When you take a look at this does not look like an efficient gait. It does not look like a very safe gait. And you're going to be exerting a whole lot of energy to just walk a couple of steps. So that's where we were. And to kind of put it in context, in the mid 1950s, I know the 50s may seem like a long way, like a long time ago, but they really weren't. And this is what was considered rehab. So I'm going to kind of read this to you. This is taken out of one of our main texts for stroke rehab. So as late as the mid 50s, the attitude of both doctors and families of patients with a completed stroke was one of hopelessness. The patients were placed in a nursing home or in a back room, usually at complete bed rest, and they were waited on and pampered on. Under these conditions, the patients usually deteriorated rapidly, and complications of decubitus ulcers, muscle spasms, atrophy, and infections were frequent. So essentially, when someone had a stroke, they were placed in a nursing home, and that was it. And that was what stroke rehab was in the 50s. Guys, again, I can't emphasize enough, that was not that long ago. Now, the issue with it and the reason why this is all that was is because there were no resources being dedicated to stroke rehab. So it really started to change in the 70s and the 80s. You started to see some stroke rehab approaches started to take form. And this was due to an increase in research and an increase in money being put into research. And it was really been since the 1990s that the literature demonstrates that a clear multidisciplinary approach to stroke care is clinically useful. Now you may say, Dr. Nick, you said you were evidence-based. You said this is just clinically useful. Where are the numbers? Well, I've got you. So this is a Cochrane review that looked at 28 trials and just shy of 6,000 patients. And it looked at patients that participated specifically in stroke unit care and compared that with an alternate service, whether that was non-stroke specific, not multidisciplinary, etc. And when I say multidisciplinary, that is where you're incorporating the physicians, the therapists, case managers, everyone, multidisciplinary team in taking care of the patient. And what this Cochrane review showed is that patients that participated in a multidisciplinary stroke care they were more likely to be alive, they were more independent, and they were living at home 1 year after their stroke. Those are all things that we all want. And so the literature demonstrates that multidisciplinary stroke care certainly is the way to go for our stroke survivors. So next, we're going to talk about this neuroplasticity. I remember it was not that long ago that I was doing my neuroanatomy courses in my OMS 2 year, and you start talking about neuroplastic changes and neuroplasticity. It's like, what is actually going on? And I think we really need to explain it because it explains how we see the recovery that we do in our stroke survivors. So if you were to Google neuroplasticity right now, this is the first thing that comes up from like dictionary.com. It is the ability of the brain to form and reorganize synaptic connections, especially following an injury. Now, neuroplasticity, or again, we know that plasticity or plastic, it's malleable, it's changing. It takes 3 different forms. So it is in both the subset of neural regeneration and neural repair. And the 3 subsets are axonal sprouting, dendritic branching, and all of what I just kind of put together as the genesis. So axonogenesis, gliogenesis, or the creation of neurons. And so when you look at this, this is just and dendrites that are branching, and then the creation or the genesis of new. Now, you may ask me, well, what is actually the most important? If you take a look at a couple of papers, it looks at axonal sprouting has the most consistently has demonstrated improved outcomes when you look at the different neuroplastic changes. So those that have more axonal sprouting seem to have more improved clinical outcomes. So let's talk about the time course of recovery. So this may or may not be a question or two that we talked about at the beginning. And this is a question that you will, for sure, if you have not already gotten this during your rotations, you will get this in PM&R residency, you will get this on your audition rotations from patients, etc. Your peak neurologic recovery occurs within the first 1 to 3 months after the onset of symptoms. And then typically what happens is you get recovery up to about 1 year, and then you start plateauing. Now that up to about 1 year is only about 5% of patients per the literature. I'll be the first one to say I have patients, and I continue to see patients every single day that are past a year from their stroke that continue to demonstrate improvements. Those patients, however, are more in the exception compared to what the literature shows. And this is this plateau here. I mentioned I'm a kind of a visual person. This is your time on your x-axis. This is recovery on your y. And you start seeing this plateau occurring at about 1 year. Now, you say, okay, if you have recovery in the first 1 to 3 months, well, what's a predictor? What's going to determine if someone does well or if someone doesn't do well? So the best predictor of stroke recovery is what is underlined. It is that initial score that someone comes into the hospital with on their NIHSS score. So this is broken down for you all for reference. A quote unquote minor stroke is considered a score of 1 to 4. A moderate stroke is 5 to 15. This kind of in the middle, moderate to severe is 16 to 20, and then severe is from 21 to 42. So what this is saying is that if someone has a has onset of symptoms, goes into the emergency department and has an NIHSS of 36, or okay, that's patient A, and then patient B goes in onset of symptoms and has an NIHSS score of 3. That NIHSS score of 3 patient would be expected to most likely recover more and have better clinical outcomes than the person that had an NIHSS in the 30s. Age does play a big role in it, but it is not the biggest predictor, and it is what you would expect. A patient that is younger has better clinical outcomes, and that's because their brain is able to undergo neuroplastic changes more readily than someone that is older. So younger patients recover more from a clinical outcomes perspective. And then the type of stroke also plays a role. Now, when I first went through this, I thought that hemorrhagic strokes or the bleeding strokes would rehab better than the ischemic, or then worse than the ischemic strokes, but it's actually opposite. Hemorrhagic strokes in the long outcome, when you're taking and looking at long-term outcome data, patients that have a hemorrhagic stroke have better clinical outcomes than ischemic strokes. So lower NIHSS is the biggest predictor. Someone that is younger is going to be a good predictor for recovery because you are able to go under more neuroplastic changes. And then if you have to pick your stroke, which God forbid you don't do, but if you had to pick one, a hemorrhagic stroke is going to recover more than an ischemic stroke, or at least per the literature. Now, we mentioned recovery. If we talk about recovery, we have to split this into 2 different types. This is certainly a paper that if you're on a stroke rotation or in a, maybe you're on a neuro rehab unit in PM&R, reading the Copenhagen stroke study would be a good one to do such. It is one paper that when I'm on our stroke service with our residency, now we're talking about this study. And what this looked at is it looked at just shy of 1,200 patients, that acute stroke patients, and it measured neurologic recovery and functional recovery. So we have to pause and we have to explain what is the difference between the two. So I'm going to kind of scoot off to the side. If you guys can see the picture, you can see my arm. Neurologic recovery is if someone says, Dr. Nick, I want you to bend your elbow, and I can do this, and I can bend my elbow. That is neurologic recovery. But if you tell me, hey, Dr. Nick, I want you to brush your teeth. Well, think about everything that has to be done to brush my teeth. I have to bend my elbow, yes, but I've also got to bring a toothbrush to my mouth. I've got to have wrist motion, finger motion. So the ability to have functional recovery requires a lot more complex tasks. Because of that, it takes longer to recover after a stroke. So the ability to just move your elbow occurs within the first 4.5 weeks. So the best neurologic recovery occurs within the first 4.5 weeks in 80% of patients. But as I just mentioned, the ability to move or bend your elbow is different than the ability to move that elbow and brush your teeth. So that functional recovery occurs, the best occurs within 6 weeks in 80% of patients. So there's about a week and a half delay between making that neurologic recovery functional. And overall, the time course for recovery is a combination of your initial stroke severity and your overall functional disability. We're talking about stroke recovery. I would be remiss not to talk about the stages of stroke recovery. So this is your textbook of what patients typically go through in their recovery process. You start off with one where paralysis is present, so that limb and that arm or that leg just does not move at all. And I'm going to skip to 7. 7 is completely normal. Now, I will say that I certainly have patients that don't go through all of these stages, and don't return back to a normal state. They may have some spasticity that we're treating in clinic. They may have some cognitive impairment. And so not everyone progresses through this, but the overall themes of each stage is very important. So that first stage is where the paralysis is present. And then that second stage, and when you know that someone is starting to go into their recovery, is when you start seeing spasticity. Or for those that may not know what spasticity is, it's that tightness or that tone in that muscle. It is velocity dependent tone that occurs after a stroke. For me as a rehab stroke doc, when I start to see if someone doesn't have spasticity yet, when they come to rehab, and they start to develop it, on one point, I get excited because I know that they're starting to progress with their recovery. But then I'm also on high alert because that spasticity is going to come fast, and I need to make sure that I stay on top of it. So when someone starts to progress, you don't have any move in that limb, but you start getting spasticity. Stage 3 is where you get peak spasticity. So that velocity dependent tone is at its absolute max. But then you start to get some movement in that limb, and you get what's called voluntary synergistic movements. Now that's a real fancy medical term to say something that I guarantee you all have seen. So again, if we use my elbow and we say, hey, Dr. Nick, I want you to flex your elbow. And when I do that, if I do this, I bend my elbow, I raise my shoulder, I bend my wrist, and I bend my fingers. And when you ask me to bend my elbow, this is what I do. This is a synergistic movement. It's where I've got other muscles trying to come to the party and help out with flexing that elbow. So it's a synergistic movement. Next time you're doing a manual muscle test on someone, take a look and see if they do that, and you may see some synergism with patients. So that's when you know you're continuing your recovery. That is stage 3. Stage 4, that spasticity starts to decrease, and then you start getting voluntary movements that are a little bit more isolated. 5 is when you get isolated movements with near resolution of spasticity. And then 6 is where you have no spasticity, and it's mostly abnormal patterns with rapid action. So those rapid alternating movements are impaired, and then 7 is normal. If you're not a word person, but you're a visual person, this is for you. So this is kind of what patients go through. So you've got the first stage is a flaccid limb. And then as you progress, that stage 3 is where you have the worst spasticity. And then 6 years where you get that isolated coordinated movement. And then 7 is just not pictured here, which was a normal state of regen. Now, the hard questions. This is something that I make it my job to make sure that every resident who I have the pleasure and honor of educating, I want to make sure that we talk about this, because these are the questions you're going to get no matter what area of PM&R that you pursue. If it's interventional pain, if it's sports medicine, if it's cancer rehab, you're going to get questions from either a family member of a patient or a patient themselves that have had a stroke that asks you about recovery. So let's talk about the lower extremity. So if the patient is able to sit at the edge of the bed independently, number 1, and number 2, has just some voluntary movement of the hip, knee, and or ankle within 3 days after their stroke, within 72 hours after their stroke, they have a 98% chance of being independent with gait at 6 months. Now, being independent with gait does not mean that they are running a marathon. Being independent with gait may mean that they are able to walk in their house with a walker independently. Okay, so patient is able to independently sit at the edge of the bed and has some movement in that leg, they have a near 100% chance of being independent with gait at 6 months. Now let's look at the opposite. So if someone is unable to sit independently for at least 30 seconds, and that limb, when specifically here, that lower extremity, it has no voluntary movement at 72 hours after their stroke, those patients only have a 27% chance of achieving independent gait at 6 months. So sitting balance and movement at 3 days after a stroke, according to the literature, is where it's at. That is the most important for your predictors for recovery and walking. Now let's look at the upper extremity. So we take a look at a particular study done in 2010 called the EPOS study, EPOS. And what this looked at is if patients demonstrate some degree of finger extension and shoulder abduction at 72 hours after a stroke, they have a 98% chance probability of achieving some dexterity at 6 months. Now, the upper extremity is a little different than the lower extremity because it recovers and progresses through recovery through this concept called fixed proportion. Fixed proportion essentially essentially states that if the corticospinal tract is intact, that is a big caveat. If the corticospinal tract is intact, that as someone recovers, you should expect to see 70% of their recovery back no matter what. So corticospinal tract is intact, 70% of their function should come back. Now, if you notice that there are some neurologists, stroke rehab docs, neuro rehab, PM&R docs, where if they're going in and they're looking at finger extension on a patient, you might wonder, what in the world are they doing? Why are they so intrigued with finger extension? That is why. Every patient who I admit, one of the things I will always have them do is see what I can get with shoulder abduction and finger extension. Now, I do know that in the acute rehab setting, it is very rare that I'm ever seeing someone 3 days after the onset of their stroke. And so it doesn't necessarily fit in this data, but if I see someone and I get some finger extension and some shoulder abduction, I know, okay, we probably have a good chance of achieving some good dexterity. So when you get those tough questions from family members, families, friends of families on are they going to be able to use their arm again or are they able to walk again? Now you have some literature to be able to answer those questions. So with the lower extremity, it's based upon can they sit at the edge of bed by themselves and do they have some movement? And then for the arm, it's finger extension and shoulder abduction. All right, let's talk a little bit about therapy philosophy. So when you talk about stroke rehab, you can think about it in not two different, but these are kind of the big overarching themes of philosophies when it comes to stroke rehab. So you have a compensatory approach. This is sometimes called task-specific therapy. So task-specific means if you are working at trying to brush your teeth, you are doing that activity with the affected limb. So it is very task specific. A restorative approach is a little different. So what this looks at is it's sometimes referred to as what's called the neurodevelopmental approach. And what this looks at is it looks at either suppressing bad stuff or using the bad stuff to help with your recovery. Let me explain that a little bit more here. So these are the three main concepts with neurodevelopmental technique. Now, there's a whole bunch of real fancy medical terms here, so I just want you to listen to me so that I can explain it to you. So the Bobath approach, it's just a name. What it looks at is it looks to decrease spasticity and synergies by using what's called inhibitory postures and movements to facilitate a normal autonomic response. So what happens is the Bobath tries to suppress the bad. So it is trying to decrease the spasticity and uses those synergies to inhibit stuff. It doesn't want to use the bad stuff. It wants to get that away so that you can use other muscles and use other type of techniques for the quote unquote good stuff. Does that make sense, everyone? The Brunstrom approach is the exact opposite. So it looks at emphasizing the synergistic patterns and using the spasticity to your advantage. Okay, so it's two very contrasting themes on stroke recovery, but it's two different philosophies that as everyone on this call is at least interested in PM&R, but for those that go to PM&R residency, take PM&R boards, this is all over our boards. Okay, so Bobath looks to decrease the bad, and Brunstrom looks to emphasize the bad. And then this technique called proprioceptive neuromuscular facilitation essentially is just using some manual stimulation and verbal instructions to induce a desired movement. Again, we like to put real fancy words with medical stuff, and when you break it down, that's how it's best to understand that. So you may ask, all right, Dr. Nick, you just really bored me with 2 slides. What is the best therapy philosophy and what should patients be doing? It's task specific. So literature has shown that you have better functional outcomes in task specific rehabilitation as opposed to neurodevelopmental. So at the end of the day, you want to complete a task, you do that task. That is what the literature shows. Now let's talk about technology. Technology is cool. It is in our daily life, whether that is from our new iPhone 14 to the medical field. We know that technology has made a lasting impact on medicine. Well, rehabilitation is certainly not immune to that, and we encourage technology as we are helping our patients recover. And these are some of the main new advances in neurorehabilitation when it comes to rehab technologies. You have transcranial magnetic stimulation, transcranial direct current stimulation. You've got robots, you got virtual reality, and then you also have vagal nerve stimulation. Now, you have more technologies that are used, but these are the ones that I'm going to highlight, and then we're going to talk about the literature that either does or does not support their use. So the first thing I've got to talk about is brain stimulation. Now, this is not invasive where you're going in doing brain surgery and implanting things. This is non-invasive electrical stimulation. So we're going to go through this process so that you have a good understanding of what the differences are between these two, so that we can look at the literature together. So this first picture here is an example of transcranial magnetic stimulation, and I'm going to call it TMS. So what this does is this takes a big old wand, and you see the magnetic field here pictured in white, and this red spot is where this patient's stroke was. So what this does, what TMS does, is it takes this wand and it puts it on the outside of the skull, and it targets it towards the area that is affected, and it delivers a magnetic field into that damaged area. It can either do it through a single pulse, so just like boom, and that's it. It can be paired, so bum, 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 or it can be a repetitive train. So that's where you have a whole bunch in a row. Now, what is this supposed to do? This magnetic stimulation is supposed to increase the intracortical excitability within the affected tissue to help induce neuroplastic changes for recovery. The other concept of non-invasive electrical brain stimulation is transcranial direct current stimulation. So that is pictured down here in the bottom right-hand corner. This is where you use a cathode and an anode. So your anode is positive, your cathode is negative, and you use, surface electrodes where you put the anode over the area where you want to increase cortical excitability. And then you place the cathode where you want to decrease your cortical excitability. So in other words, this is honing in and targeting the area that you want to affect, just like you do here, and then you provide your stimulation. So do we feel comfortable a little bit with the differences between the two? See a couple of head nods. So before we get into the literature, we have to remind ourselves what the level of evidence shows and what it means. So with all of the pictures that I'm going to show you, it looks at studies that either have level 1A, 1B, or level 2 evidence. Remember, level 1A is the best. It's randomized controlled trials, and it's got more than one higher quality randomized controlled trial with a Pedro score greater than equal to 6. You want to take a look at that. That is essentially rates how good randomized controlled trials are. And then your 1B is you've got randomized controlled trials, but 1B only has one higher quality RCT. And then your level 2s is where you start getting into not only RCTs, but prospective controlled trials and cohort studies. So 1A, 1B, and 2. Remember, 1A is the best. Now, these next slides, you're going to see a bunch of pictures. And this graph can look very intimidating at first. But let's talk about what we're actually looking at. So with each one of these graphs, it's going to measure an intervention or a technology that we've talked about. And it's going to look at what particular aspect of that intervention, and then what is the functional measure that they are looking at. Now, within each of these, green means that the intervention, that the data supports the use of that intervention. Yellow is kind of like a not so fast. And then red is where that intervention is not supported for that particular functional domain. And then within each box, it has the level of evidence and the number of RCTs that are total. So when you look at this, before we get into the nitty gritty, we got to make sure we understand this. If you've got something that is green with 1A evidence for 20 randomized controlled trials, that's pretty good evidence to suggest that whatever technology this is really helping patients. But then if you take a look down here to the bottom right-hand corner, you've got level 1A evidence in 6 randomized controlled trials that is red. And that means that the intervention certainly does not support its use in this particular regard. So that's how you look at these. These are actually created from some systematic reviews that are done by our colleagues in Canada. They do a really nice job of synthesizing our available stroke research. So we're looking at our brain stimulation. When you look at TMS, so that's the one with the wand, and you do the big picture, you can see that you've got quite a bit of green here to support its use. But when you get into the nitty gritty, when you talk about low frequency, and we're not going to get into the weeds about low frequency, high frequency, etc. But you have evidence to support that low frequency transcranial magnetic stimulation. When you look at motor function, you've got 20 randomized controlled trials with 1A evidence to support its use. So that's a pretty powerful change to say, okay, I want to use this in my clinical practice. Now, when you keep looking, you've got 10 randomized controlled trials and 9 randomized controlled trials that supports its use and improvement in dexterity and ADLs. You have a couple of studies here that are not supporting its use for decreasing spasticity or increasing range of motion. And then you've got one randomized controlled trial with 1B evidence looking at proprioception or proprioception. And then you've got for stroke severity and then muscle strength. So that's how you look at these. And we're going to just we're not going to go through each one of these painstakingly because you would want to just log off right now. But we're going to hit the highlights into how this might change or how this might influence your decision as someone is on the stroke rehab unit or coming to you in follow-up, and how you might be able to use technology for that. So when you look at high frequency TMS, you've got some studies that aren't done yet, but then you have some decent number of randomized controlled trials that support its use for dexterity, ADL, stroke severity, and muscle strength. Now, we're going to look at its counterpart. That's where you got the cathode and the anode. So transcranial direct current stimulation. And if you take a look back and you just look at it from the big picture, you would say that you've got a lot of reds and a lot of yellows, and that is true. But what I want to draw your attention to is that when you start getting into what's called dual transcranial direct stimulation, you got a couple of studies that support its use. But at the end of the day, when you look at this, you would say that TMS has some good literature to support its use in stroke recovery. And then TDCS, at least when you take a compile these this level of evidence, that there's some things, and the overwhelming majority really doesn't support its use right now. Now, that was for the upper extremity. If we're taking a look at the lower extremity, and what we add here is balance and gait and final ambulation distance. When you look at TMS, again, you see a whole lot of green. So you would say, hey, although there's only a couple of randomized controlled trials with each, there's evidence to say, hey, TMS does a pretty good job of helping our patients. And then TDCS for lower extremities kind of all over the board. You've got a couple of studies here that are red that don't support its use, a couple that are unequivocal, and then only 3 randomized controlled trials that really demonstrate some benefit. I promise you that is the most boring part of the technology, okay? But you guys have to, it's exciting stuff, right? We're doing non-invasive brain stimulation on patients to help with their recovery. That is some really awesome stuff. Let's get to virtual reality. So as we know, virtual reality is a way to interact with an alternate universe. You have different types, right? When the Nintendo Wii first came out, you had a stick and you did some bowling with some friends and that was it. Well, now you're putting on goggles and you're entering a whole new universe into a virtual reality. So there's different forms of virtual reality. And the overall theme is that you have mixed evidence. I think the biggest thing to take home is that virtual reality does demonstrate improvement in motor function with 30 randomized controlled trials in our stroke patients. So, I mean, that's a lot. That's, I won't say it's a slam dunk because nothing in medicine is a slam dunk, but gosh, virtual reality is really helping our patients in that regard. And then I want you to look at virtual reality with use of a treadmill. So the virtual reality with use of a treadmill has demonstrated improvement with balance and with gait. Let's next talk about robotics. So this was one of the questions that we talked about. And the reason I have that question is several fold. One is that you have to have some education as to what is the difference in robotics. When I was in residency, I had no idea. You would have told me an end effector and I would have said a what? And so when we talk about robotics, these are the differences. So an exoskeleton device is right here in A. So what this is supposed to be is an external skeleton that is helping patients with whatever type of motion that they are performing. So this here is to demonstrate the humerus. This here is to demonstrate the radius and ulna. And it is outside of the skeleton, but within the area of where you would expect it to be, with the joints appropriately aligned as well. An end effector is where you have a robotic device that has an effect at the end of it. That's how I keep it straight. So it here is attached to this individual, but then it has an arm that comes out, and this is where the effect is taking place. So exoskeleton tries to mimic the skeleton. End effector is the end of the device that's having the effect. Now that's for the upper extremity. When you look at the lower extremity, this is a lower extremity exoskeleton device that you see. This is in it's not recent, this is a couple years old, but this was a news release. And then this is an end effector treadmill that this individual is pictured. This is just taken off the internet, off of Google. But this is what an end effector device looks like for the lower extremity. So that end effect is coming here within the treadmill. So what does the evidence show? If you take a step back, you don't see a lot of green. What I do want to draw your attention to is final ambulation distance with the end effector robot. So kind of like those treadmills that we saw. You've got 8 randomized controlled trials with 1A evidence to support its use. Now, taking a look at the upper extremity, you've got 4 randomized controlled trials with 1A evidence to support hand exoskeleton devices in ADLs. Now you may wonder, Dr. Nick, why did you pinpoint this to talk about it right here with the hand exoskeleton? And the reason is I'm seeing it day in and day out in clinic. I'm having patients coming to me and saying, hey, Dr. Nick, I found this on Amazon. Do you think that it could help me? And it is a $250, $300 hand exoskeleton device that my patients are putting money into to help them recover. And what I tell them is I'm like, listen, this is what the literature shows. If you have the means to do so, and it's not going to strap you, the literature does support its use. And I have them make sure that they take it and work with therapy and try to have them incorporate it. But people are able to buy this stuff online nowadays. And so that is why I talk about it, because I literally had someone kind of turn their phone to me and say, hey, Dr. Nick, what do you think? And I'm like, cool, like that's awesome. It's an orange color. Like, what's the literature show? And that's when we started to talk about this. The last thing I want to mention is vagal nerve stimulation. You're going to see this more and more. So in an article in the Lancet in 2021, it looked at vagal nerve stimulation paired with rehab for upper. This was a randomized triple-blind sham-controlled study, so the best that it gets. It looked at 108 participants. 53 of them had a vagal nerve stimulator placed, and 55 of them had a fake vagal nerve stimulator placed. And this looked at what's called a Fugel-Meyer score, which is essentially a scoring system that we use in stroke rehab research. And what this looked at is at 90 days, when you paired true vagal nerve stimulation with a very regimented program for rehabilitation, the between group clinical significant difference or clinical difference was 24% with a p-value of 0.0098. So at the end of the day, vagal nerve stimulation paired with an appropriate rehab program for upper limb function really makes a difference. And you're going to start seeing this more and more. So what's next? As I mentioned to you at the very beginning, I hope that at the end of this, you can use this info to discuss potential prognosis. And at the end of the day is provide hope. I feel like that is what I'm in the job in, is when I talk to patients that feel down, they aren't back to where they are. They've had some of their functions that they used to be able to perform taken away from them. I talk to them about that recovery is possible. I do this every single day, and I hold this job with so much responsibility, and I'm so grateful that I get to do this every day, and I get to provide hope to patients to say, hey, this is what the literature shows. This is how you're doing. These are the gains that you are making. This is where we're going to go. We're going to do this together. Patients knowing that they have someone that's also in their camp going through it goes a really long way. So with those questions that we started off with at the very beginning, if I did my job, these are going to be pretty straightforward for you all. So peak neurologic recovery after a stroke occurs within the first 1 to 3 months. So answer was D. What is the most important predictor of stroke recovery? That was the initial stroke severity score, NIHSS. And then which of the following robotic devices demonstrates the best improvement in ADLs and upper limb recovery after a stroke? And that is the hand exoskeleton. But everyone is showing me on Amazon and all that. So those are my references. and I'm going to stop sharing. And I'd love to see what questions you guys have done.
Do insurances cover most of these types of device therapies, or is it something you'd have to go into like a formal rehabilitation setting in order to even have an option of using it?
Yeah, so it's kind of the answer is a combination of well, it's a combination of both. So one is normally big academic centers have these technologies, and we have them here at UK, but most academic centers do. They are very expensive, and insurance companies don't pay for them for the most part. So for folks in rural communities in like private rehabs, it is so difficult to try to utilize some of this technology, just because, right, if you're a CEO of a rehab hospital in like a community setting, and you're offered $500,000 to get or you have to pay $500,000 to get a exoskeleton lower limb device, and the literature doesn't really demonstrate its support, why are you going to invest $500,000 in it? And so that's, not only the literature, but a lot of those places don't have that finances to spend. So what I do with patients is if we have clinical trials going on that use technology, getting them involved with that, or having them come to rehab at an academic center that incorporates this technology. Very good question.
I know we kind of have a mixed bag between M1s and M4s in here. Can you kind of talk about what spasticity looks like? I know we don't have to go into the MAS grading, but can you kind of talk about what spasticity looks like in general, and then kind of the role of botulism toxin injections for that as well?
Yeah, absolutely. So spasticity is an overarching term for what's called velocity dependent tone. We all have tone in a muscle. Sometimes it's more than it should be. Sometimes it's less than it should be. Sometimes it's just right, like Goldilocks' porridge. So if you were to put my arm in a cast and cast me just like this for 6 months, and then you were to take it off, I would have a very rigid muscle. But no matter what speed you were to try to move my arm in extension, that tone would not change. Spasticity is where that tone changes based upon the velocity at which you test it. So if you go slower, it might be a little less. If you speed it up, it might get a catch, and then it goes away. And there's multiple grading scales. The one we mostly use is called the modified Ashworth scale, used to assess spasticity. And then the second part to that question with utilizing botulinum toxin. So botulinum toxin works in the synaptic cleft, and it works presynaptically by inhibiting the release of acetylcholine into that synaptic cleft. And so what happens is when you don't have acetylcholine, you don't have muscle contraction. And so the hope is that by injecting that toxin into that muscle, that it's being taken up by the presynaptic bulb. You're not releasing acetylcholine, so that you decrease that bad tone in that arm.
Can you talk about, oh, sorry.
No, I was gonna say, did that answer your question, Dylan?
Yes, it did. Thank you.
Awesome. Yeah, go ahead. So sorry.
No, can you talk about your role with, especially inpatient, with PT, OT, speech, and what the function of you as the physician is? Because of course you want to do as much therapy as you can with your patients and everything else. The interaction between kind of the role division between you and versus PT, OT.
Yeah, that's an excellent question. So I love our physical therapists, occupational therapists, and speech therapists. They do an amazing job. And without them, I couldn't do my job. And I like to think that without us, they couldn't do ours. But when it comes to what is your role as the rehab doctor, so you're collaborating with your therapist all the time. So like, for example, today, it was a couple days ago, we were talking about spasticity in a patient, that was limiting what they were able to do with their ambulation. And so then we talked about what muscles are specifically being affected in their ambulation and what is particularly spastic. And then we thought, okay, well, what is the best treatment? And so do we need to use botulinum toxin? Do we need to use a nerve block? Do we need to use baclofen? What or some other type of medicine? Do we need to start some medicines to decrease their tone so that they have improved recovery? Do we need to go a different route? Also working on the medical side of managing orthostatic hypotension is a huge thing that therapists and I are always talking about. And when you start going through all of the issues after a stroke, neurogenic bowel and bladder, neuropathic pain, aphasia, we can play a very large role with medication improvements and to augment that recovery. And so for me, I'm talking to therapists every single day. And then we have a big meeting, a formal meeting called an interdisciplinary team conference, which is where kind of some of the paperwork has to come into play about how well our patients are doing, et cetera. But I'm talking to the therapist every single day. I encourage you, and I do this with the residents I work with and students, is we'll go see patients in the gym. Because when you're seeing them in the gym and you're seeing them working, you're going to get the best idea of how they're doing, and then where you can intervene as a physician.
Dr. Nick, I was going to ask, as a stroke and neuro rehab doctor, what is kind of like your day-to-day schedule look like each week? Like, how much are you in the hospital? How much are you in clinic? And like, what kind of possibilities are available?
Yeah, so for me, I have 2 half days of clinic, Tuesdays and Wednesdays. And then the other days I'm on the unit. So my day typically starts around 7:15, 7:30. I round. We have about anywhere from 8 to 12 patients. Our cap is 12 patients on each teaching service. And then we're rounding on everyone. I like to do flow rounding personally. So I'm taking a computer as we go, putting in orders, doing some notes as we go, just to limit the amount of work when we get back. And then I get back and we kind of run over the list with the residents and students if we have students with us. And then we kind of divide the work that notes and stuff that might be kind of just out there. And then we're kind of, once we get everyone tucked in, then we're working on admissions, or depending on what day it is, I like to do not only clinical teaching at bedside every day, but doing some whiteboard education. So talking about landmark papers, I like to do that at least 2 afternoons for an hour or so a week. And then, like I said, working on admissions. And then I like to kind of sneak back into the rooms with our folks and say, hey, how did therapy go? Any issues overnight? Because I like to try to make sure that if there are issues, that I take care of those before the night team comes in.
Can you speak about how much OMM, whether I know maybe you don't do it as much with your patients, but what the role OMM plays in your patient's recovery?
Yeah, I love that question because I've kind of carved out a tiny little niche for myself in using the OMM and neuro rehab patients. So my clinic has kind of become into utilizing OMM and MS patients, spinal cord patients, stroke patients. At the end of the day, realize that just because someone has had a neurologic issue, that doesn't mean that they are immune to musculoskeletal issues. So where I see a lot is if someone's left side is weak, but now their right side is getting a lot more force, and that's where you're starting to get a lot more somatic dysfunctions, a lot more issues from a musculoskeletal standpoint that I can incorporate OMM into. One example is on the inpatient unit, someone had a lateral epicondylitis because they were using their right hand more since their stroke. We did some myofascial release and some OMM, and they were pain-free within a couple of days.
Thank you.
Yeah, absolutely. Guys, I probably have time for one more question and then I unfortunately have to go to another meeting. I'm so, so sorry. If you guys have questions that come up, as I put in the chat earlier, my email and my cell